All right. So Bernadette Greenwood, we are pleased and honored to once again welcome Bernadette as our guest speaker. Ms. Greenwood is a CRO, the Chief Research Officer at Halo Diagnostics in Indian Wells, California. She comes to us with over 30 years experience in medical imaging, marketing, clinical education, regulatory affairs, product management, and R&D. She lectures frequently on topics related to oncologic imaging and is an internationally recognized expert in prostate MRI and MRI-guided intervention. With her boundless energy, she has also been a tireless and vocal patient advocate, working with US2 International, Zero Cancer, and local prostate cancer support groups. In 2010, the team of Bernadette Greenwood and Roger McNichols, PhD, developed a unique focal treatment for prostate cancer called LITT, which we know as focal laser ablation. The first case in the world was performed by the Halo Diagnostics team of Dr. John Feller, Dr. McNichols, and Ms. Greenwood. In 2014, she founded the International Laser Network to bring together international experts on laser focal therapy. Ms. Greenwood is the study director for an ongoing phase 2 LITT clinical trial, which has just published very favorable 10-year results. We're looking forward to hearing more about these results and much more tonight. Ms. Greenwood, welcome.
Thank you so much for the kind introduction. I hope everyone is doing well under these very unusual circumstances. It's the first time I've done a virtual meeting for this group, and I hope you enjoy it and learn from it. If anyone has questions as I move along, feel free to interrupt me. At the end, we'll open up Q&A, of course, and I apologize, I have a little bit of allergy laryngitis, but hopefully it doesn't bother anybody too much. So my main disclosure is that I have a patent pending for a system and method for MRI-guided interstitial thermal therapy. This is the technique that I invented for transrectally delivered laser focal therapy of prostate cancer. Tonight, we're going to talk about the history of biopsy strategies, the evolution of multiparametric MRI, technical aspects of MR-guided biopsies, rationale for MR-guided laser focal therapy of prostate cancer. I'll give you an update at Ethan's request on NCT 02243033, which is our phase 2 clinical trial. We'll discuss tissue-based genomics. We'll also talk about circulating tumor cell blood tests. If time permits, I will share with you a 5-minute video of myself and Dr. Richard Ablin, the developer of the PSA test that aired recently on NBC Palm Springs. So just so you all know, my earliest work was in breast cancer research and development of products for breast cancer detection, staging, and biopsy. Much of what I did in that realm is easily transferable to prostate. I mean, it's 2 different organs, 2 different body parts, but many of the things that we do in the realms of imaging and intervention are very similar. And my philosophy has long been, if it looks like a skunk and it smells like a skunk, it's probably a skunk. So if I could see it, I could stick it. And if I could stick it, I could get the Gleason score, I could get tissue-based genomics, and I can potentially pop a laser fiber inside there and do a treatment. So early on, I looked at all kinds of energy sources that might be amenable to being delivered transrectally, and I made a chart, and I documented the attributes and the drawbacks of each of those techniques. And the thing that came out on top every single time was laser. So that's why Dr. Feller and I went that direction. People often ask, well, why don't you do HIFU, or why don't you do RF? Why don't you do cryo? Because when you rack and stack these energy sources against one another, the thing that comes out on top is always laser. And I'll show you why in a little bit. So let's take a walk through history in the literature and talk about the evolution of prostate biopsy, which is the basis for what I developed. So early on in the 1920s, they would do an incision in the perineum and dig around in there until they felt something they want to put a needle in. Not very accurate. Then Astraldi et al. Came up with a transrectal biopsy technique involving inserting a gloved finger into the rectum, putting a stainless steel sound down the urethra, and palpating the posterior back part of the prostate and delivering a needle that way. And while that might have been better than the other way, it's still not as good as we have today. Then in the 60s, Watanabe-san and his team in Japan came up with the first clinically useful transrectal ultrasound images. And in the same year, McNeil et al. Proposes a glandular zonal anatomy diagram. So whether you're a radiologist, whether you're a pathologist, or a surgeon, whatever you are, you're talking about the same neighborhood, the same way as everybody else. Then in the 80s, we had the evolution of transducers for ultrasound, or probes for ultrasound. These transducers used to be just used on the outside of the body. Then we came up with transvaginal and transrectal transducers, which I used in the early 80s to do follicle count for fertility for women, to look at how many follicles are kind of ripe on their ovaries. And then we also use them for imaging the prostate and other pelvic structures when delivered transrectally. And then in 1986, despite the fact that Dick Ablin developed the PSA in 1970, the FDA approved it for prostate cancer screening in 1986. And then in 1989, Hodge et al. Developed the sextant biopsy, which was simply taking 3 cores out of the left part of the prostate, 3 cores out of the right part of the prostate. Then Stamianescu said, well, if 6 cores is good, then 18 or 24 or however many might be better. But the problem is, what if the tumor is here? What if the tumor is here? I don't care if you take a sample at all these locations. If the tumor's here, you're going to miss it. And this doesn't take into account depth. This is just left-right direction and front-back direction. It does not take into account the depth of a big gland. So a man could have a very large gland with a far cancer, and you could take 100 biopsies and you'll miss it year over year over year. And we see this in clinical practice. Then Winston Barzell came up with a schema for saturation biopsy, which is every 3 millimeters, taking a core over the entire gland. Again, you've got the same problem. What if it's here? What if it's here? What if it's here? And again, this is anterior, posterior, and left and right. It does not address depth. So if it's a large gland, you could do a 64 core biopsy, it'll be negative. You could do a 90 core biopsy, it'll be negative, and the man will be harboring clinically significant cancer that's never picked up. So to show you what saturation biopsy looks like, my friend Dr. Tom Palasic, professor of surgery, Department of Urology at Duke University, loaned me some slides. And this is his gloved hands in the reflection of the ultrasound monitor. And he's holding the handle of the transducer. And you can see on the image, this white border here is the inferior wall of the urinary bladder. The black stuff there is pee. And this gray blob in the middle is the prostate. The white line is the needle going into the prostate, and they shoot it in there like 64 times. What are we getting samples of? We don't know. My degree is in imaging science, and I don't know where the tumor is here because it's ultrasound. Ultrasound can only show you the margin of the gland. It can't show you where the tumor is. Unless, of course, you have a fused image where MRI is laid on top of it, you may be able to do a better job aiming at something meaningful, but this is just an example of what saturation biopsy looks like. And then again, once we do ABC, 1, 2, 3, I sunk your battleship, you end up with this. So for me, whenever people complain to me that MRI is expensive, I tell them pathology is expensive. When you look at each of these as $200 to $300, or even if you group them by groups of 4 and they're $300, you know, this is a 3, 6, 9, 12, 15, 18, 20-something $100 histologic evaluation. So anytime somebody complains about the cost of MRI, I hit them with this. And so this is funny but unfunny. When you look at what we do with the saturation biopsy, it's like, oh, the results were negative, but at the same time, the poor guy is harboring clinically significant disease. The first MR targeted biopsies in bore inside the MR scanner were done at a beta site of In Vivo, which is the company that I worked with to develop this and commercialize it. And these are just some images of what a MR targeted biopsy looks like. And I always ask audiences, what do you want guiding your biopsy, this ultrasound or this MRI? And I mean, like, I'm no rocket scientist, but I think this image is a little bit more helpful than this image. And we've come a very long way. Back in 2009, the National Comprehensive Cancer Network guidelines pretty much were bad test after bad test after bad test. And if it's negative, repeat the bad test year over year. But now we've got better guidelines that began evolving in 2012, where multiparametric MRI was mentioned for the first time. Then the European Society of Urogenital Radiology published their 2012 guidelines, after which the ACR PIRADS guidelines followed shortly. So I serve on the ACR PIRADS committee for protocol optimization and the site designation committee, as well as the ADMITech International Working Group Prostate MRI committee. So I was very honored to be able to provide input for this document. So when we look at PIRADS, it's a if this and that, then this kind of algorithm. If it's dark on the T2 sequence, if it's dark on the ADC sequence, if it's bright on the high B value sequence, and if it sucks up contrast really quickly on the perfusion or dynamic contrast sequence, probably a good idea to put a needle in it and see what it is. So we're very fortunate that no matter where you're getting your prostate MRI done, there are many vendors that do a great job with software and color overlays and segmentation and pharmacokinetic modeling. So there's lots of tools that radiologists and scientists have at their disposal to make sure that we get not only the best images on you, but also the best output from those images, because there's data, information, quantification that we can derive from that MR data. And speaking of deriving information from your PSA, we can calculate PSA density. So PSA density is simply PSA divided by gland volume. So imagine a patient with a gland the size of a golf ball and another patient with a gland the size of a grapefruit, and they each have a PSA of 4. Well, the guy with the smaller gland is going to have a higher PSA density, which is a very good prognostic indicator, and we'll get to that later. The guy with the grapefruit size gland with a PSA of 4, no worries. He's got a very low PSA density, okay? So make sure no matter where you're going and you're getting your PSA done, can they calculate your PSA density? If they've never done an MRI on you, they can't. If all they've done is a digital rectal exam, they can estimate your gland volume, but they can't feel the front of it. They can't feel both sides of it. All they could feel is the back, the top, the bottom, and a little bit of the left, a little bit of the right. They can't feel the whole thing, which is why imaging is so important. Imaging will show the extent of disease. It will show gland volume. It will show extraprostatic extension, and it will allow you to calculate a very accurate PSA density. Finally, in 2016, the National Comprehensive Cancer Network published their recommendation that multiparametric MRI followed by lesion targeting may maximize detection of high-risk disease and limit the detection of low-risk disease. Again, I am not a rocket scientist, but it makes sense to me that if you take a picture, you might actually be able to pick up the stuff that's real and ignore the stuff that's not. So in October 2019, the American Urological Association updated their policy statement on the use of MRI for diagnosis, staging, and management of prostate cancer, and pretty much said pretty much any guy getting a biopsy should have an MRI first. So if anybody is sticking a needle, a finger, or a scalpel in you before they've done an MRI, put the brakes on. Just put the brakes on and ask them, have you read the policy statement? Have you read the NCCN guidelines? Because if they're not imaging you before they intervene, they're going in blind. So back in 2006, my colleagues at the university where I'm pursuing my PhD did a great study about accuracy of 3 sequences in MRI, no spectroscopy. They got rid of it. We got rid of it about 9 years ago. It's a pain in the neck. It doesn't add much. And, you know, you use it in a research environment. It's fun, but it doesn't add much on a clinical day-to-day basis. So even without spectroscopy, the accuracy, negative predictive value of multiparametric MRI is 91%. That's a very good test. And then the team at Yale duplicated those results in 2016 and ended up with 96.2% negative predictive value for clinically significant prostate cancer. This is a really big deal because in the hands of skilled users, we're able to achieve imaging and we're able to interpret those images to the tune of almost 100% negative predictive value. Unlike the transrectal ultrasound guided random systematic biopsy, which misclassified disease, depending on what paper you look at, somewhere on the order of 40 to 45% of the time. So when somebody gives me pushback and says, whoa, MRI misses clinically significant disease 4% of the time, I turn the spear around and say, well, transrectal ultrasound guided biopsy misses it almost 50% of the time. So help me understand how that's okay. So we're going to talk now about the inverse relationship between apparent diffusion coefficient value and aggressiveness of cancer. But before we do that, I'm going to talk to you about field strength. We've got people marching around the planet saying, oh, if you don't have your prostate MRI on a 3T, it's a bad facility, it's a bad place, they don't know what they're doing. And that's utter nonsense. And I'll tell you why. The vast majority of magnets in North America are 1.5T. Only about 10% of them are 3T. All the rest are less than 1.5T. And I know for a fact, as the person who developed a lot of the instrumentation for intraoperative MRI over the last few decades, all of the instruments that we use are RF induction tested and FDA cleared for imaging in the body to field strengths up to 1.5T. So for the intraoperative procedures, we love 1.5T. And what a lot of people won't talk about is things that are bad at 1.5T are worse at 3T. Things like breathing motion that will blur the image, things like digestion, bowel gas, peristalsis. All these things will cause blurring and smearing and spatial distortion and spatial misregistration. And these things are worse at higher field strengths, which is why if you walked in my office right now and you opened up a textbook on intraoperative MRI, you'll see that for many years, intraoperative MRI was performed at field strengths less than 1 Tesla, less than 1 Tesla. So that being said, the things that matter way more to me than field strength are the skill of the operator, needs to be a credentialed, accredited individual, experienced with MRI and MRI physics and how to set up protocols. The software needs to be modern, state-of-the-art and able to perform diffusion with very high B values, either acquired or calculated. The choice of the coil. Are you using an endorectal coil, which I personally don't like. It's intrusive, it's expensive, it offers no benefit to us personally because we use a high channel count surface coil. And years ago, I published a paper about patients who don't have a rectum, whether it's because of a birth defect or whether it's a surgical change that made the rectum inaccessible. So if I have to develop a protocol and a coil capable of imaging the guy with no rectum, why would I just not do that on everyone? And that's always been my position. People always ask me, when are you going to develop an endorectal coil? The answer was never, never. I have no interest. So we use a very high channel count surface coil, and patient preparation is huge. If a guy has a bean burrito for lunch and comes in for a 2 p.m. prostate MRI, it's going to be worthless. You can't eat for 8 to 10 hours before your MRI. Some facilities will inject an anti-peristaltic agent to slow digestion, and some places will actually have you do an enema before your MRI. And these things are good. These things are meant to calm down the pelvic involuntary motion that will create our artifacts and blurring and other problems with the image and the image interpretation. And then lastly, the interpreter. You could have all 4 of these other things aligned perfectly, but if the interpreter is inexperienced and has no strong background in body MRI and body imaging, you're going to get a report that's essentially worthless. So let's take a look at the difference between a 1.5T MRI done at our facility and a 3T endorectal coil image done at an ivory tower academic institution. Well, right away you could see, I could see the effaced peripheral zone here really well. I think this maybe could be the cancer. I'm not really sure. I've got some artifact running through here, little zipper artifact going through here, some more like Gibbs truncation artifact going through here, and then the entire front part of the gland is obliterated. I could do some things to make this better, but what I do to make the front better makes the back worse, and vice versa. So, but here we just use a really nice surface coil, and then people will argue, whoa, it's gonna take longer. Yeah, like 7 seconds, 14 seconds. We're not talking minutes, we're not talking hours. It may take 7 or 14 seconds to get this compared to this. So do not be duped and do not be convinced that 3T is the be all end all, because it's not. Don't be convinced that an endorectal coil is the be all, the end all, because it's not. Now, there's some facilities that will use an endorectal coil because their magnet is so old and so outdated, they need to do anything they can to buy back signal to get a good image. I get that. But anybody that's using state-of-the-art equipment should not be inserting an endorectal coil into you. Let's look at another case. Same patient within a week. Look at this arching white line going through the image, blurring the image and kind of blurring the prostate gland right here. This is a 3T image, and this is our 1.5T image. And you could see the cyst, you could see the BPH, you could see the peripheral zone, you could see bones and the rectum. You see everything beautifully, no problem. And it took, well, 7 seconds longer, no big deal. Let's go back again to the relationship of apparent diffusion coefficient value and aggressiveness of cancer. So the higher the ADC, the lower the Gleason score is the general accepted rule of thumb. High ADCs can also be an indicator of infection or inflammation, but usually if it's cancer, it's very low grade, nothing to worry about. The higher the ADC goes, the higher the Gleason score goes. And the darker the image is on the ADC, the more aggressive the cancer. So
means lower the ADC, right? The lower the ADC, the more aggressive.
The lower the ADC, the higher the grade. Excuse me, sorry about that. Then let's take a look at what this means to us. So where we get the ADC value from is we scroll a cursor all around the tumor and we find the spot that gives us the lowest ADC. So where do we want to do the biopsy? Well, the ADC here is 691. You move that cursor over just a couple voxels. Now all of a sudden the ADC is well over 1,000. I don't want the biopsy from here. I don't want the tissue-based genomics from here. I want it from here. So that's why we always scroll around and we seek out the lowest ADC component of the tumor. So again, what's wrong with truss biopsy and saturation biopsy? You have a 1.7 centimeter throw into the gland. And so if you've got a great big cancer, very aggressive cancer sitting right here, you're going to miss it. year over year over year over year. PSA is going to go up, it's going to double, it's going to triple. METS happens, metastatic disease, bone cancer, lymph node cancer. Meanwhile, this thing is going outside the gland. Nobody ever picks it up because they can't reach it. That's this problem. The other problem is that bad actor is sitting here, but you pick up something inconsequential that you think answers the question. Oh, whoa, it's 3 + 3. Go on active surveillance. But wait, we got this thing hanging out right here. Also, you could have a bad actor with a really aggressive component where the ADC is very low, and then you just scoot over a little bit and the ADC is higher, and you pick up this bit of tissue and you miss that. So it's totally misstaged and misclassified. So the team at Radboud did a study back about 10 years ago comparing 10-core biopsy to MR-targeted biopsy. And for Gleason score 7 or greater, look at the yield for MR-guided biopsy and look at the yield for 10-core biopsy. Don't even need a p-value to say what the benefit is. So Dr. Feller and I have been very active publishing many articles on what we've learned over the last 12, 13 years in terms of biopsy. And for the patient, it's really no big deal. You lay on your stomach, little needle guide goes in the rectum, coil goes in the front of you, the back of you. We have software that shows us where that needle guide is. We take aim, we look at where the tumor is, we align everything so that we could angle left, right, front, back, insert head, foot, and aim the needle right into the most aggressive part of the tumor. And then what we end up with is a needle trough with a sample in it. That sample goes into formalin. That formalin goes off to the lab with the tissue inside it. At the lab, they cut and stain it. It goes under the microscope of the pathologist. They then render a histologic diagnosis or Gleason score. We get a report that I designed with our pathologists that talks in bright red letters, what the heck is going on? What's the worst of the worst? And then we have a table. How many cores were taken? How long were they? How long was the cancer? What percent of that core was cancer? What was the Gleason score? And any narrative description of what else might have been involved. Then our pathologist will always include a JPEG image of the needle in the thrown position, along with a photomicrograph of the tissue. So literally in a court of law, it is indisputable where the tissue came from. This is very important. I'll explain why later. So Gleason scoring is, to me, essentially Skittle sorting. Gleason grade determines Gleason score. So when the pathologist puts that specimen under the microscope, they're looking at cellular architecture throughout the length of that core and that entire specimen. And they document what there's the most of and what's the second most. That's the primary Gleason grade and the secondary Gleason grade. So let's take patient number 1. He's got mostly Gleason 3 for primary Gleason grade, and mostly Gleason 4 for the secondary Gleason grade, the sum of which is 7. So if the next patient comes in and his specimen is dominant Gleason 4 pattern, primary Gleason grade, and secondary Gleason grade 3, the sum of which is also 4, the second guy has the worst prognosis because the more aggressive cell type is dominant in his Gleason 7. So hopefully that makes sense. And that's how Gleason score is determined. Now, when our team gets patients in, we always talk about NCCN guidelines. There's traditional therapies, state-of-the-art, gold standard. What we do is a clinical trial. It's experimental, but we let patients know what's available to them based on their staging exams and their clinical history. And then if they meet the criteria for our laser focal therapy study, we discuss that with them and help them determine if that might be a reasonable thing for them to consider. So the laser focal therapy is performed just like the biopsy. That picture I showed you of the guy laying on his tummy with the thing in his rectum, we use that exact same device. That's my index finger. I'm a little person. This thing is smaller than my index finger, and it acts two ways. It is both a receptacle for a laser fiber, but it's also a fiducial marker. So we could see on the MRI image two bright lines that help our software calibrate and aim at the area that we're targeting. So all these devices are FDA cleared. It's a visualization platform that was originally used in brains in children for intractable epilepsy to get rid of temporal lobe tumors. And my philosophy was if I could stick it in the brain of a kid safely, I could certainly stick it in a prostate. And all the laser apparatus are also FDA cleared. What we did was we put things together that were FDA cleared and used them off label as part of a clinical trial, because the biopsy system is FDA cleared for biopsy and intervention, but the laser and laser visualization platform is FDA cleared for soft tissue necrotization, not for cancer treatment. So there may or may not ever be an on-label application for it, but physicians continue to do it because they possess a medical doctor license and it's their prerogative if they want to use it. So the other laser fiber that we use is called a Tranberg laser out of Sweden. This laser is non-cooled, it's very strong, and we expose the laser fiber, about 5 centimeters of it, in order to deposit energy over very short periods of time to achieve kill zones of almost a centimeter. So this is a turkey breast that I did way back when we first started testing it. So you see untreated tissue here, treated tissue here. So I got about a 7 millimeter burn in about a minute and a half. And this is the team that helped me with that experiment. What a lot of people don't know about MRI is that not only do we get a beautiful picture from it, but we can do things like measure tissue contrast, flow quantification, perfusion of contrast into blood vessels, diffusion or movement of water molecules between cells, and phase shifts, which is what helps us calculate with this RNAS modeling the temperature maps that we use to monitor how hot tissue is getting over the course of the treatment. So we're able to look at the temperature map, an irreversible damage estimate, and an anatomic image in 2 planes, and we're able to see what we're cooking as we cook it. And we get a temperature graph, and we have little cursors that we're able to put over things that we want to protect. So this long tumor right here, we're able to sculpt a therapy around it and tell the system how hot we want to make it. And then we got cold cursors here that we call safety cursors, and we put those over important things that control urination, erectile function, and other important anatomic structures. So we're able to protect things and reduce incontinence and impotence. This is a case we did way back in April 2018. This man had a prostatectomy. His cancer came back at the area where the urethra is reinserted back in the bladder. It's one of the most common places for cancer to recur post-prostatectomy. And I just said before and after, tricky. So here's the cancer before, and there's a black hole after. So laser can be used in the salvage setting after radiation, palliatively, after prostatectomy as salvage, after brachytherapy, after proton. Doesn't matter. We've got a large cohort of men that have been treated with other techniques where there is about a 30% recurrence rate at 10 years. So we're able to go in there and clean that up and buy them additional time. So here's an image of a test dose where we just administer a little bit of energy right before we start the therapy, making sure that the energy is coming off in the right spot. Once we confirm it's where it belongs, we up the energy and we burn for up to 2 minutes. And here's the irreversible damage estimate. These blue cursors are the protective safety boundaries. And this technique was originally presented in 2011. We didn't give away like the secret sauce or anything, but we just let the world know that this is something that can be done safely and that is actually feasible. Here's a nice case showing a Gleason 3+4 cancer. And this patient, you could see dark on the T2 sequence, bright on the high B value, dark on diffusion. Now you see it, now you don't. Here's a large treatment area where that tumor used to be. Here's the thermal map. We achieved temperatures over 63.9 degrees Celsius. And here's the irreversible damage estimate. That's in the axial plane, slicing like a loaf of bread, top to bottom. Here's that same treatment in the sagittal plane, slicing side to side. So this is the top of the treatment, this is the bottom of the treatment, and you could see the large area that was burned, coagulation necrosis was induced, and the visible tumor on MRI is gone, as well as a large margin around it. So initially we wanted to just treat what we saw, but we learned quickly that if you do that, it comes back. So you've got to treat what you see and a margin around it. And then this patient came back for a 6-month biopsy, no problem, totally negative, he's doing just fine. So part of the reason why we're able to achieve such good oncologic control with such precision is because when you look at HIFU, high intensity focused ultrasound, or radiofrequency treatment, or cryoablation, freezing, the transition zone between the treated or dead tissue and the viable tissue can be as thick as 5 to 10 millimeters. Look at that, see how that is? So, but when you do laser, the transition zone is less than a millimeter. So here's the dead tissue, and here's the viable tissue. So we're able to get very close to important structures without doing damage. That's why the side effect profile for these other focal therapy techniques is so poor. Here you've got a large, thick transition zone, and now, you know, this is all dead right here, and I'm assuming that this black stuff is carbonized, but then what's this pink stuff over here? Is it alive or is it dead? I don't know. So anyway, when I originally did my research to create this surgical technique, I looked at all energy sources and, like I said, racked and stacked them against each other. And I tried hard to prove laser didn't work. In my efforts to prove it didn't work, I proved that it did, and it works really well. So the update on our clinical trial, we have an IRB approved protocol with 510K cleared technology. However, we are using it off-label. The NCT number on clinicaltrials.gov is 02243033. It's an outpatient laser therapy using a 15-watt laser with a 980 nanometer diode at 1.5 Tesla. It is true focal therapy, as I just described to you. Our goal is to eliminate the MR visible abnormality with a 1 centimeter margin around it for the reasons I described just a moment ago. So in 161 patients, we did 255 lesions. This is as of last quarter. We're now approaching 180 patients and about 300 lesions. Our 6-month biopsies were performed, MRI active surveillance follow-up. We measure PSA density, do MRI, look at recurrence rates, marginal recurrence rates, and de novo incidence cancer, out of field recurrence rates. We look at International Prostate Symptom Score, which is a measure of urologic function, the Sexual Health Inventory for Men, which is sexual health measurement, and the PHQ-9, which is a personal health questionnaire that measures emotional well-being. So in terms of tumor location, the vast majority of tumors that we've treated have been in the peripheral zone, a fair bit in the transition zone, and then others elsewhere. That's in all patients. In our treatment naive cohort, in other words, the men that have never, ever, ever, ever been treated for the prostate cancer with anything, the vast majority, again, are in the peripheral zone, and then some in the transition zone, and very few in the central zone. In our salvage population, in other words, men that have had brachy, prostatectomy, external beam radiation, proton, androgen deprivation, whatever, these men, we've done mostly in the peripheral zone, a bunch in the transition zone. We've done central zone, seminal vesicles, bladder wall, and other locations with extraprostatic extension. The goal to debulk these things, prevent metastatic disease, and prolong life. So it's palliative in these guys. In these guys, the goal is oncologic control that's durable. In terms of Gleason score breakdown, I get personally offended when I read or hear people saying, oh, well, Greenwood and Feller only treat 3+3. And that's not only not true, but we do treat 3+3, but it must be MRI visible large volume 3+3 in men with abnormally high PSA densities. That's the 3+3 group. The vast majority of what we treat in all patients, in treatment naive patients, and in salvage patients is Gleason 7. In salvage patients, we take all comers, 7, 8, 9, 10. In terms of PSA after therapy, in all patients, we see a PSA decline of around 40%. In the treatment naive group, it's around 34%. And in the salvage patients, because they tend to present with much higher PSAs at the beginning, once we treat them, by 12 months, we see a PSA decline of around 70%, 70. Sexual health inventory for men results, everybody bounces back to nearly baseline. We have almost no statistically significant impotence. When we talk about International Prostate Symptom Score, urologic function bounces back by 12 months, no statistically significant incontinence in any of these groups. Everybody goes back to baseline. PHQ-9, our overall results, everybody stays emotionally stable, but let's look at what happens with the treatment naive guys. They stay stable and then they get happier. The salvage patients, here's what happens with them. You know, they kind of bounce around a little bit and then they're really happy at the very end. I think at 6 months, they start worrying again because it's time for the 6-month biopsy, and then they get happy. 6-month biopsies, when we talk about clinically insignificant disease, something we're not going to do anything with, in all patients, that's about 15%. Clinically significant disease, things that we need to pay attention to, monitor closely, or retreat, around 20% in the entire group. When we break that group into treatment naive and salvage, what you'll notice is in the non-treated cohort, clinically significant cancer is only 17%. Clinically significant cancer in the salvage group is 37%. Remember, we're not going in there for cure with these men. We're debulking tumors. We're getting rid of as much as we can in the environment that we're in. And we know for sure there may be some residual or recurrent disease, but the goal is to prevent metastatic spread and to prevent lymph node involvement. Excuse me. When we look at the rate of metastasis and the rate of death among our prostate cancer patients, at 10 years, we've only had one man develop bone mets, and he was treated with systemic therapy and he's still alive. And at 10 years, we've had no prostate cancer specific deaths. In other words, no man in our study has died of his prostate cancer. We've had 5 men pass away of other causes, but that's the reason why I tell all my patients, be sure you see your dermatologist every year and be screened for metastatic melanoma. I also tell our patients to make sure that they're getting good exercise, eating right, and avoiding cardiovascular disease. I mentioned earlier PSA density being a wonderful prognostic indicator. So when we look at the patients who had positive 6-month biopsy, the vast majority of them had PSA densities of 0.22 or more. The positive clinically insignificant disease patients had PSA densities of 0.17, and the guys with negative biopsy had PSA densities of 0.15 or less. So I think that this is a really good thing for us to continue to study. So stay tuned on that front. I wanted to touch briefly on biochemical recurrence rates for radical prostatectomy and radiation therapy for intermediate risk prostate cancer. It's 20% at 5 years post-therapy, and it's 30% at 10 years post-therapy. So, you know, here we sit at about 10 years and we have like a 17% rate. So not doing too bad, not inferior to standard of care. So I think it's worth pursuing as a first-line treatment. So while laser, it's safe, precise, it's outpatient feasible. You walk in, you walk out. We could sculpt therapy and avoid things that are important. The transition zone between dead and viable tissue is only 1 millimeter compared to 5 to 10 millimeters for other focal therapy sources. We're able to do biplane real-time thermometry with safety cursors, so we see what we're doing in 2 planes from head to foot and side to side. And in addition, we're really able to get into the apex of the gland. When you look at the prostate, it's shaped like a peach, and the very bottom of it comes to a point, and being able to get in that little sharp, tricky place, we're able to do that really easily, especially if we use a urethral cooling catheter with continuous bladder irrigation, and then also cancers in very large volume prostate glands. So the one guy that worries me is our whack-a-mole. So if the guy comes back at 6 months and his prostate cancer has recurred in the treatment area, but it's also popped up in 2 or 3 more places, we're not going to play whack-a-mole with that guy. We're going to talk to him about other treatment options, unless, of course, he's a very poor surgical candidate for other medical reasons. We may treat the whack-a-mole if he's got other things that make him a bad surgical candidate. But 9 times out of 10, we're going to say, you know, it might be time for prostatectomy or radiation. So to sum it up, you know, our 10-year interim data in well over 150 patients shows that MR-guided transrectal laser focal therapy is safe and feasible in an outpatient setting. We've had no significant erectile dysfunction, incontinence, or rectal toxicity. Our results for quality of life exist without limiting or eliminating the other options. They remain on the table. Patients can go on to whole gland therapy or have additional laser focal therapy if they want. Short-term and intermediate-term oncologic control is achieved in over 75% of our research subjects. It's a minimally invasive outpatient therapy. They walk in, they walk out. And in specific patient populations, for example, HIV-positive patients, quadriplegics, patients with coagulopathy and other morbidity, laser focal therapy is a very, very attractive option for them. Dr. Feller likes to say nothing ruins good results like follow-up, which is why we're watching our men for 20 years. This isn't something where you pop in, we image you and biopsy you at 6 months and say, yay, success. No, we look at you, watch you, monitor you for 20 years. So that's why I have a number of people backfilling me, because I'm not sure where I'm going to be in 20 years, but this is an ongoing observational study with anticipated publication in about 20 years. Excuse me. But we do publish our interim results. I can't post those to clinicaltrials.gov because it's a 20-year study and all you can publish is your final results. You cannot publish interim results because they may be misleading. However, every year at RSNA, ASCO, AUA, every scientific meeting that I get abstracts accepted to, I present our interim results. I created a international multi-institutional phase 2 trial looking at those numbers. There's an ongoing IRB-approved clinical trial exploring tissue-based genomics for risk stratification, and I am doing IND submission for FDA approval of combination therapy using oncolytic virus and laser to get our recurrence rates down even lower. And I mentioned tissue-based genomics because for me, it's a really good thing to help me understand who is a real good candidate for focal therapy, and more importantly, who might not be a good candidate. Men at high risk for recurrence and metastasis probably should not be treated with focal therapy, but we've been studying and exploring this over the years using different genomic tests for about the last 8 years. The ones that I've used the most have been Prostavision, a 2-gene panel consisting of ERG and P10, and Decipher, which is a clinical panel of 22 genes, but I also have a research protocol I do with them that explores the entire human exome, 1.4 million genes and pseudogenes. Decipher used to be only available postoperatively. After prostatectomy, they would slice the prostate, go to the area of tumor, extract RNA, and then do the test to establish a low, intermediate, or high risk profile. So about 7 years ago, I approached the developer of this test at the American Urological Association meeting, or AUA. And I'm like, look, when are you going to offer this for biopsy? And he goes, never. And I said, why not? And he said, well, biopsies are garbage. They're random. You don't know where it's coming from, et cetera. And I said, well, what if I gave you gold? What if I gave you tissue that was taken from the most aggressive appearing component of a tumor with the lowest apparent diffusion coefficient value? How much of that tissue would you need to be able to give me a result? If I give you a 1.8 centimeter core that's 20, 30, or 40% cancer, is that enough material for you to extract RNA and give me a decipher score? He said, let me think about it. So fast forward to February 2016, he released Decipher for biopsy, which is a 22 gene panel. We also have an experimental 35 gene panel that we developed, a 46,000 marker panel, and we're doing the whole human exome, which is 1.4 million genomic markers. These are the beautiful reports that we get. I'm not going to go into the aberrant genes and what they mean to me, but suffice it to say that clinically, I'm able to look at, do you have a low, do you have an intermediate, or do you have a high risk profile? Depending on where you fall on this little scale here, that's going to guide our counseling and our informed consent with you. So Decipher's been around forever. We know its value. We know about its ability to predict prostate cancer specific mortality. We're using it as part of an algorithm to prognosticate and do risk stratification. In other words, to eliminate men from active surveillance and focal therapy if they have a high risk profile. So we'll look at two cases quickly. Here's a guy, 67, had a Gleason 4+3 in the right peripheral zone, had 2 negative transrectal ultrasound guided biopsies. Surprise, surprise. His PSA was 8.3. We lasered him in September 2015. The nadir, or the lowest level that his PSA went to after treatment, was 0.58. And we look at his intermediate Decipher score, his low risk Prostavision score, boom, he had a negative 6-month biopsy. Not surprising. Next case, the 60-year-old had large volume MR visible 3+3 with a PSA of 5.4. We lasered him January 2011. His nadir, or low level after therapy, went to 4.1, which isn't too big a decline. Then his PSA crept up to 6.3 in August of 2012. We repeated his laser, and then his nadir went to 3.4. Well, unsurprisingly, his PSA went back up to almost 6 in January 2016. We repeated the laser in August of 2016. Look at his genomic score, 0.82. He's in the high risk category. So you might think, well, but you lasered him in 2012 or 2011. How'd you know his genomic score if the test wasn't released till 2016? What I did was I went back in my phase 1 cohort and I explained to all these men that this test was just released, and with their informed consent, I would procure their pre-treatment cores, the cores that were taken before they had their first laser, excuse me, and I would run the Decipher on that tissue. That's how I was able to derive their low, intermediate, or high risk profile. And what I've been finding over the last 10 years is that our Decipher scores are aligning really, really well with clinical outcomes. So Radke et al. Published this great paper back in 2017 talking about transcriptome-wide analysis of MR image targeted biopsy and matching cervical specimens from high-risk prostate cancer patients treated with radical prostatectomy. The target must be hit. That is the bottom line. You know, whatever we're doing with genomics, we can't take tissue from random places and hope to get an answer. We have to aim the needle at the thing that's most worrisome. In our small cohort that we evaluated a couple years ago, we had 105 guys. Vast majority was Gleason 6, some 3+4, some 4+3, and a handful of 8, 9, 10. When you look at the distribution of 5-year metastasis risk, you know, you've got a broad spectrum among those patients, those 105 guys. But when you look at them distributed and correlate their PSAs, what you see is guys with low PSA have high risk, guys with high PSAs have low risk. So PSA and metastatic potential don't necessarily jive. We then compared Gleason score 3+3 risk to Gleason 3+3 PSA. And again, it's a weird distribution. It doesn't align. Same with 3+4, weird distribution. It doesn't align. Again, 4+3, same thing. And 4+4 and higher, same thing. So PSA by itself, I'm not going to say it's worthless, but what I'm going to say is we could get more information if we do tissue-based genomics and if we do PSA density. And here's a histogram showing the vast majority of our men had low risk disease. Some had intermediate risk and fewer had high risk disease. But these are the guys that we want to keep a close eye on with 3-month PSAs, circulating tumor cells, imaging, and periodic biopsy if indicated. So one more thing that we've introduced into our program is circulating tumor cells and circulating tumor DNA that will not only help guide treatment decisions, but help us understand if we've achieved oncologic control in patients undergoing laser focal therapy. So we measure circulating tumor cells pre-laser, and then we measure them at 6 months, and then again at 12 months. This test is also available for non-small cell lung cancer. It's also available for breast cancer, colorectal cancer, gastric cancer, ovarian cancer, and melanoma. And on that note, I'm going to back up here and go back to one of the cases that I showed you. This gentleman who had the PSA that kept bumping up and bumping up and bumping up and ended up with a high-risk score, I went in and I looked at his whole human exome. This guy was overexpressing a thing called glutathione peroxidase, which is not only a prostate cancer marker, but it's also a colorectal cancer marker. He ended up developing lymph node mets from a colorectal primary. And imagine if back in 2011, you know, we did his laser in January 2011, so he must have done his biopsy in November or December 2010. If I had known what was going on with him, he likely would have undergone colonoscopy, and maybe we could have prevented what ended up happening. But this is just a really, really strong story to validate why genomic testing is so valuable in terms of clinical management. So one thing to point out is circulating tumor cells are never, ever, 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 ever found in the blood of people that don't have cancer. So that's why before our laser therapy, we measure circulating tumor cells, see how many there are, and we're watching how much that number goes down after therapy. And so it's a bit of an experiment right now. We just implemented it about 6 months ago, so we'll see what it shows. And I like the fact that not only do I get circulating tumor cells by number, but I also get circulating tumor RNA. So I'm able to see certain types of genes and pseudogenes that are overexpressed or deleted. So these reports are really helpful. So what we covered in this hour was the history of biopsy strategies, the evolution of multiparametric MRI, technical aspects of MRI-guided biopsies, the rationale for MR-guided laser focal therapy of prostate cancer. I gave you a brief update on the 10-year interim results of our 20-year observational study. We discussed tissue-based genomics as well as circulating tumor cells. I know a lot of you want to know, like, does she have any disclosures, like who's paying her, yada, yada. I'm not getting paid to say anything I say. I'm a PhD candidate at Radboud University in Nijmegen in the Netherlands under Professor Jürgen Futterer and Professor Jelle Barents. I'm the co-founder of the International Laser Network and a clinical instructor at the Department of Internal Medicine at UC Riverside School of Medicine. None of this work would have ever been possible without my dear friend and colleague, Roger McNichols, who passed away. Also, Dr. Stuart May, who is no longer with us, our interventional radiologist, the leadership of Dr. Feller and him listening to me, understanding my vision and helping me execute it. Our MRI technologist, Wes Jones, who is at the helm for every MRI guided biopsy, and every laser. We've got Axel Winkel from In Vivo Germany, who was so generous to create custom devices for me over the last 11 years. And then Rob Toth. Dr. Toth is a PhD biostatistician slash software writer slash inventor, graduate of Rutgers University. He is our outside biostatistician who runs reports on our data every quarter of every year. So no one can say at a scientific meeting, oh, Bernadette and Dr. Feller's numbers look really good because they ran their own analysis. That's not how it works. We have an outside institutional review board that approves our research, and we have an outside biostatistician that analyzes our outcomes. And with that, I want to thank you all for your attention and open the floor to questions, should there be any. And right here are the NCT numbers for the laser focal therapy clinical trial and the Decipher clinical trial.
So thank you. First of all, Bernadette, are you still recruiting for this clinical trial?
We are.
Okay, that's an important thing to know. All right.
Yes.
Okay. The other thing about it, and I'm just asking this because I think there is some interest. This is not paid for by the institution, right? This is
No, and you raised a really good question. So I have not received a large R01 grant from the NIH. I have no funding from the VA, and I have no funding from the DoD or any other entity that would make it covered by insurance or by a grant. So this is around $25,000, and I realize many patients can't pay that. So about 7 years ago, I had a patient give me a check for $250,000, and I started a foundation called the Focal Therapy Foundation. And I pushed it away from myself. I am in no way associated with it because I don't want to be the person performing the procedure and telling you if we could pay for it. That is a humongous conflict of interest for me. So the Focal Therapy Foundation is a volunteer board that looks at financial need, and they scale contributions based on need. So the initial $250,000 has been nearly exhausted, but one of my patients that we treated about 6 years ago just replenished it a little bit. So we do have funds there. They are available. The application process is purely online. Calling me will not help you. Emailing me will not help you. You have to go through a bit of a painful process. It takes about a month, but if you meet the criteria, you will get full or partial contribution from the foundation. And it's called the Focal Therapy Foundation. And the website is www.thefocaltherapyfoundation.org.
We'll put that on our website, Bernadette. That's important information.
Sure, and let them know it's scaled and it's truly based on need. And I'll give you an example. I had a guy who really wanted therapy, and they found out he had a yacht. And they're like, no, we can't pay for you. You've got a yacht. So you can't, yeah, you know what I'm saying.
Sure. And one other thing, because there is some interest in this, and so tell us a little bit more about what your 25 grand covers. I mean, what?
Yeah, so the actual amount, we've kind of modified it over the years based on how many people are in the room with you, what are their credentials, what's the hourly use of the magnet, what's the cost of the equipment, and what is the capital outlay for the laser. So the $24,900 covers the laser on the day of the procedure. Mm-hmm. It covers the immediate follow-up, whether it's 2 days or 7 days or however long it is, until we do an ultrasound of the bladder and meet with the urologist and talk about urologic function and look at before and after pictures. It covers that. Then at 3 months, we don't do anything. All we want is surveys and a PSA. Then at 6 months, you return to us for MRI and MRI targeted biopsy of the treatment site. That is covered. And I want to remind you, even when we don't see anything, even in the absence of imaging findings, like on this patient, we saw nothing, but we still put the needle in 2-3 times just to make sure there was nothing microscopic brewing that might declare itself later. So that's covered. And then the MRI at 12 months is covered as well. And if we see something worth biopsying, that would be covered. Then after 12 months, then we go back to insurance and it's active surveillance.
Okay. All right, that's good. So that's, in other words, that does not cut in case you need to be retreated. That is not covered, right? That's extra.
No, and that would be 50% instead of 24,009. That would be 12,450.
Okay.
And very early on, it was much less. And what we were doing was suffering because, you know, you've got a surgeon in there, you've got an interventional radiologist, you've got me, you've got a tech, you've got a sedation nurse, you've got the equipment, you've got the disposables. So it's very difficult to justify doing a $12,000 procedure for anything less than about $12,000.
Okay, understood. Okay, very good.
And just so your participants know, Halo Diagnostics is not an imaging center company. What Halo did was they went out in the world and their leadership had very bad experiences with family members that passed away from cancer. And these gentlemen are billionaires that have nothing to do with their free time than find solutions. One of them was with the McKinsey Group. He's our CEO, Michael Ewell. One of them was the 32nd employee at Google, our Chief Product Officer, Brian Axe, who invented Google AdSense. And the guy that invented the cloud, VMware, Aram Campo, is our Chief Technology Officer, and I'm Chief Research Officer, and Dr. Feller is Chief Medical Officer. So our executive team is very keen on using technology and artificial intelligence and machine learning to ease the patient's worries, to turbocharge the imaging process, to harmonize workflow, and also to optimize things like billing, scheduling, reporting. All those things are so disjointed by the very nature of imaging. Everything is its own thing. So what we're working to do is create a platform that we will disseminate nationwide. We've got 20-something imaging centers now. We're going to have 36 by the end of the year. And by the end of 2021, we hope to have 100 imaging centers in North America. Dr. Feller and I recently traveled to Trinidad and Tobago. We established a prostate cancer program for that country. I'm good friends with the Prime Minister, and he asked me one day, why can't we do what you do? And I said, well, let's come show you. So we invited all their urologists and radiologists to come see us and spend time with us. And they called us up and said, you know, the Minister of Health said it would be cheaper if we got everybody in a conference room here and you two came here and taught us, and then you come visit our public hospital and we'll do 4 cases together and optimize everything in a day. And it was a really beautiful experience. And we created a little tunnel, an FTP server. So every case from Trinidad and Tobago comes to Dr. Feller as a teaching case. Because he's not licensed to practice medicine in that country, he is allowed to teach there. So the radiologist will provide the images and the reports and the clinical data to us. Dr. Feller will look at it and give them feedback on what they may have done right, what they may have done wrong, and then they modify their interpretation based on his feedback. So it's a really wonderful relationship that we've established with that country. And I've also been to Kosovo, to University of Pristina, and help them launch their prostate program. And we hope to continue doing this worldwide because clearly it's needed, and especially in Trinidad and Tobago, because I don't know if you know this, but they have the highest prostate cancer mortality in the world.
Oh, that's amazing. So that's kind of okay, so Halo is an organization that was started pretty recently, and so the goal is to actually to create centers all over the country that have
Right. So our mantra is innovate, create, validate, and replicate. That is my mantra. So when Michael, Brian, and the rest of the executive team were searching around for a thing to make a difference, they stumbled upon us. I gave them a tour. They met Dr. Feller. They met with multiple members of our leadership team, and they said, we like this. And so when we merged, we didn't merge, like I said, as an imaging center. Our Indian Wells is our current innovation center.
Mm.
We're going to build a larger one that will encompass all the things we're doing with exomes and RNA and genomics and genetics and PET-CT, new radionuclides. Lutetium-177 would be wonderful. I'm looking at getting gallium-68 and DCF-PYL. That's on our horizon. So the Innovation Center is where I play with things. I develop things and play with them. And if I like what I see and it does good for the patient, we run with it and we replicate it across the enterprise. If I do it and I'm puzzled and I don't understand why it's behaving the way it is, or if it doesn't make sense, or if it doesn't correlate with clinical outcomes, and I'm going to go back to this slide, and I'll show you, I experimented with a number of genomic tests, and I only use 2 for a very good reason. Whenever I'm investigating a thing, I make a matrix. I go in Excel, I create a spreadsheet, and I document PROS division. What's it doing? How's it working? Confirm MDX. What's it doing? How's it doing? What are the benefits? What are the drawbacks? And I do it with everything. And then whatever comes out best on paper, that's what I run with, and I abandon everything else. So I am a fan of Vince Lombardi, who said, do few things and do them well. So that's where we sit with our oncology program. It's primarily prostate, but we are branching into lung, ovarian, breast, colorectal, melanoma, the big ones. So that's something to keep your eye on in the future.
It sounds very ambitious.
That's how we roll.
Well, okay. We definitely need people out there who are, looking forward. I think one of the concerns of patients, and I'm just from speaking with so many people, is that we feel that the traditional institutions are very slow to respond to innovation.
Oh yeah, yeah. No, I've had a lot of academic institutions actually contact me and say, how can we do what you're doing? And I say, quit the ivory tower and come to private practice, because you want to know what? We have a committee of 2. When I think of a thing and I want to implement a thing, I chat with Dr. John Feller and we decide together, does this make sense from a clinical management standpoint? And is it economically sound? I mean, the last thing you want to do is go buy a $7 million PET-MR system that's going to do no better than MIM software with PET-CT. See what I'm saying? So our great advantage is we've been on the planet for a combined 95 years. Okay, we've been doing what we've been doing for a very long time. A lot of these academic institutions, they've got residents and young interns that think that they developed a propeller, or that they developed, variable bandwidth. It's like, whoa, hang on, that was devised 30 years ago. It's not new. So we have to be very careful when we're implementing new things. They've got to be, number 1, beneficial to the patient. Number 2, economically feasible, maybe not now, but at least down the road, and that it does no harm. I mean, that's
right.
How we have to do it.
Well, we all know that prostate cancer diagnosis and treatment are both kind of tricky, right? They're tricky because so much depends on the skill of the reader.
Yep.
So much depends on the genomics of the cancer. and
The
some of them,
immunosuppressive ability of the patient. So
some,
I don't know if I ever told you, we have an HIV positive limb to our study. I might have mentioned that during the lecture. So these are men who are not good surgical candidates. And if I can minimally invasively attack that cancer, I've done two things. Hopefully I could achieve oncologic control for him and not upset his immune system. And I've spared the surgical team the exposure to blood and other potentially infectious material. So that's another avenue that we've explored
that's great.
and
That's great.
published.
That's great. But you know, what you're trying to do, the innovation side of it is so important. And we're very, very happy to hear about these things.
Well, I'm honored to share it, and I thank you kindly for the invitation and the opportunity to give you the latest update on where our heads are at and where our innovation is going. So thank you again.
Okay, all right.
I know your team is going to have your group chat and all that. So unless there are other questions or comments, shall I bid you farewell?
I have a question.
Hi, Preston. How are you?
I'm good. Thank you for your presentation. Really helpful. So if I wanted to get this treatment, where can I get it?
We have a site in Houston, Texas, and we have a site in Indian Wells, California. There are other human beings on the planet doing it, which is why I formed the International Laser Network. There was a site that was getting a lot of rectal fistula. They were burning holes in patients' rectums. And I learned about it by going on the FDA MAUD database and learning who was dying and who was getting hurt from laser. Excuse me. The patients who were dying were all brain patients. When you leak fluid into the brain, you create intracranial pressure that can become unmanageable and the patient dies. Doesn't happen in the prostate, it comes out the rectum. Patients who were getting rectal fistula, they required surgery. And so instead of walking up to the person having this problem and going, hey, what do you think you're doing? I said, I'm going to form a club. We're going to meet at the AUA every year, and we're going to meet at the Radiological Society of North America every year. So there were 11 sites that joined us. Mayo Clinic, Emory University, UTMB, Radboud in Nijmegen, Toronto, Desert Medical Imaging, which is now Halo, private practice in New York, private practice in Houston. Who am I missing? Two more. Oh, NYU, which wasn't really doing it, UCLA, and that's about it. So, but the difference between us and the rest of the world is who's doing it transrectally, who's doing it transperineally. And I love when people say, oh, you're doing it transrectally. Oh, big scare, infection. Gee, wait, have we not been doing biopsy transrectally for 40 years? Whoa, you weren't so scared back then, but now we're doing therapy transrectally and it's a big problem. Yeah, you can't have it both ways. So we chose transrectally for the pure fact that basics of geometry, the distance from point A to point B, the greater it is, the more opportunity for skew, right? The shorter the distance, the less opportunity for skew. So when I go through the perineum or the crotch, I'm going through skin, fat, fascia, muscle, penile bulb into the prostate. So we're talking a good distance. When I go through the rectum, boop, we're there.
Good. Bernadette, before we let you go, you mentioned the site in Houston. Is that independent from Dr. Karamanian?
That is Dr. Karamanian, and we just partnered with him last week.
Oh, okay,
he
great.
is Halo now.
Wonderful. Okay, I've heard really
Yep.
good things about him.
So have I. And, Dr. Karamanian did a lot of heavy lifting to get that practice up and going. He consulted with me on every level and Dr. Feller, and we are very confident that he will be an excellent site.
Okay, very good.
And I'm going to share my screen again, only because I had an afterthought. You or Jim had mentioned that you wanted me to talk a little bit about screening and where we sit with PSA. So because I'm suffering laryngitis, I'm going to bring up a little video, and I'm hoping that it that it goes well. If it doesn't, at least listen. You don't have to look, at least listen to what we're saying. So let's run with this. Can you see it?
You have to share your audio too, if you don't. Yep, got it.
That men's health is important, not just during COVID-19, but in fact all year round. And we have two really highly esteemed experts with us. We have Bernadette Greenwood from Halo Diagnostics, and we have the very esteemed Dr. Richard Ablin, who in fact is credited with discovering the PSA back in 1970. Welcome to both of you.
Thank you for having me.
And
Thank you.
Dr.
It's a pleasure.
Thank you. Dr. Ablin, if I may start with you first, since you are credited, of course, with discovering PSA, tell us what in fact is a PSA.
Well, PSA stands for prostate-specific antigen, and it's a substance that's produced by the prostate gland, which is about the size of a walnut. PSA test measures what we call, as I said, prostate-specific antigen in the serum or the blood. Prostatitis, which is an infection, and in some cases it also can be caused by diet. Also what we know as benign prostatic hypertrophy, which is often abbreviated BPH. This is an enlargement of the prostate, which most men will experience about the age of 40. And then we have cancer of the prostate, which is a malignancy of the prostate, which is the second leading cause of death in cancer in men, behind cancer of the lung.
Bernadette, how does a doctor actually use the PSA?
Well, there's a few ways. In screening, it could be used to see if somebody has suspicion of prostate cancer. And in the setting of patients with a family history, it's nice to get a PSA on them also. And in African Americans, the guidelines say at a younger age, African American men should be screened with PSA.
How do the men in our lives know if they're at risk for prostate cancer?
Well, the couple things that I mentioned a little bit earlier, ethnicity has something to do with it. Generally speaking, African American men have about a 2.5 time risk of mortality compared to their non-African counterparts. Because prostate cancer has no real symptoms unless it's very advanced and the patient has bone pain or other symptoms of advanced disease, it's kind of a tricky, elusive cancer. And so it's really important that if a family member has been diagnosed or died of prostate cancer, or if there's African ethnicity in the patient's ancestry, that they definitely get screened in accordance with the AUA and NCCN guidelines, and that it be a shared decision between the care provider and the patient.
So Dr. Ablin, what has changed in the management of having an elevated PSA?
PSA is not cancer specific, and that is because it can be elevated in prostatitis, benign prostatic hypertrophy and enlargement, and also cancer of the prostate.
Dr. Ablin, I really wanted to underscore what you said about the American Urological Association policy statement, which was released in October of last year, 2019. It's really important that people understand that in Europe and in the UK, their guidelines state no man gets a biopsy unless he's had an MRI first. And now that we've got that policy statement, men can now, before having a random systematic biopsy where they just take sort of blind samples out of the prostate, now they have the benefit of an MRI image that shows the tumor, and the needle can be placed right in the most aggressive looking part of the tumor.
So Dr. Ablin, what would be the next step for the men in our lives if they do have an elevated PSA? What should they do?
The way to look at a PSA test for a man is that be aware that PSA cannot by itself diagnose prostate cancer. But what it can do is, Bernadette and I try to explain, we have three diseases of the prostate which can cause an elevation of PSA. So if you find that you have an elevation of PSA, look at it as a smoke alarm, not as a fire alarm. Go to your urologist if you haven't already, and have your urologist do a more extensive examination.
The men in our life shouldn't be inhibited by insurance concerns. They should definitely get an MRI.
I can't speak on behalf of every single insurance company, but what I can talk about is thousands of patient encounters and 0 rejections for properly performed MRIs under the right indications. So if a guy says, I want to have an MRI this morning, they probably won't pay for it. But if he says, my father just died of prostate cancer and I have an elevated PSA, those are things that have correct indications for billing purposes and should be covered.
Well, thank you, both of you. We've learned an awful lot today, and I know we're calling it Watch Wednesday because we're going to continue this conversation and dialogue, and we're hopefully going to make sure that the men in our lives are well aware that they must be ever vigilant about their health. Thank you so much for joining us today.
It was a pleasure.
No, thank you so much, and I appreciated seeing Bernadette, and again, meeting you, Miss Newton.
Thank you so much. Good health.
Thanks.
Stay well.
Okay, Bernadette, that was very, very nice. And like you say, MRI is becoming now a very important tool. I just wanted to ask one thing about it.
Love you, period.
One of the,
What was that?
Hi.
Room for Elizabeth.
Yeah. Sorry.
Surprise!
I love it.
I still have YouTube going. Hang on, let me kill it. I had a YouTube ad going. Sorry.
so Bernadette, so MRI is a very, very important tool, but
Absolutely. Never let anyone put a
Okay,
needle, a
but-
finger, or a scalpel anywhere near your prostate unless they do an MRI first.
sure, MRI, but also it's a very, very operator dependent. You want to make sure that you're getting MRI and an MRI read by a very, very competent reader. Now, as MRI becomes more and more available and more accepted, you're going to have that issue. Not every reader is going to be the very best.
That's right.
And so now there's this whole discussion in the world about combining MRI with biomarkers to improve the area under the curve.
We call that radiogenomics. Yeah, so we have companion diagnostics, and there's something that we're developing that I can't really talk about right now, where we take multiple factors into account, such as PIRAD score, genomic markers, other stuff, and we're putting it together in an algorithm, and we're using machine learning and artificial intelligence to do predictive modeling, because the days of the nomogram are gone, okay? The Catan nomogram, while it existed, was a great thing in that era. Parton tables, amazing in that era. It's the year 2020. We've got radionuclides, we've got MRI, we've got genomic testing, we've got genetic testing, BRCA1 and 2. If a man's got a mom that died of breast cancer, he may himself develop breast cancer. And oh, by the way, he's at increased risk for prostate cancer. So there are multifactorial components to predictive modeling and clinical management. And we're looking at it all and
Okay.
turbocharging it.
Yes, I understand, but very specifically, when a guy is presented with high PSA, before going to a biopsy, the tools that are available they're available very widely are MRI and biomarkers like PCA3, MDX. There's half a dozen of
There's
them.
dozens of them.
Okay,
But the
so
thing is,
those two tools alone, those two tools can improve the area under the curve, can improve
right,
specificity and sensitivity, right?
right.
Okay,
Yep. And some people call it companion diagnostics. We call it radiogenomics. There's pretty much two definitions of radiogenomics. Some people view radiogenomics as how genomic patterns change after radiation therapy. That's one thing. But we see it as partnering imaging and genomics together to be able to do predictive modeling and to be able to get a clear clinical picture of what might happen down the road.
Sure, but for us patients, when we go to our urologist, he says, "Oh, you have to have a biopsy."
Nope.
We have these two tools that we should present to the urologist, right? Get me the biomarker and get me an MRI. Those are both very available. They're not expensive,
Right.
and together they improve. And so then you can have that discussion whether, well, if you have those two, do I still need a biopsy, or maybe you don't, right? So it can really reduce.
You can dodge the biopsy with something called ExoDx. It's an exosome test that may be an indicator that biopsy is not needed. We began doing it about 3 months ago, but you've known me for a long time, Ethan. I don't do anything regularly until I've been doing it for a year or two, and I want to see how it performs. I know they publish papers. I know the marketers say they do this, they do that, but I want to experience it and see how it performs in true clinical practice. To do it in a research setting and publish it as a clinical trial is one thing, but how does it behave in the community environment, in an outpatient setting with regular people? So when I know more about that, I didn't include it in this lecture, but when I know more about that, I'll be sure to share.
Okay, very good. All right.
All right, I will let you get to your coffee, tea, and discussion. And should anyone have questions, you know where to find me, Bernadette at halodx.com. Thank you again for having me. All right, take it.